Thank you for joining us today for our webinar regarding key compliance considerations for medical device manufacturers in the wake of COVID-19. My name is Sam Bernstein, and I'm a partner in McGuireWoods Healthcare Group. And I focus my practice on representing medical device and pharmaceutical companies regarding a wide range of compliance and regulatory matters. Also joining us today is one of our star associates, Neshko Radovich.
Good afternoon. Good afternoon. It's a pleasure to speak to you today. As Sam mentioned, my name is Neshko Radovich, and I'm a healthcare associate with McGuireWoods' Chicago office. I regularly counsel medical device manufacturers on compliance with anti-kickback, self-referral, and other state and federal fraud and abuse laws. Additionally, I regularly collaborate with Sam in devising and maintaining compliance programs for our medical device and life sciences clients. Sam.
Thank you, Neshko. Today's presentation is the first of 3 webinars in a series that we are focusing on the medical device industry. The second webinar in this series will be in 1.5 to 2 months, and we'll be addressing compliant discount, rebate, and bundling models, including value-added services. And the third webinar after that in the series will be addressing key contracting and liability issues for negotiating supply agreements. If you have questions during our presentation today, please submit them via the presentation system, and we'll hopefully have time at the end to address them, or if we run out of time, we'll get back to you shortly offline. Today we're going to talk about a number of different topics. The first is going to be the enforcement environment during COVID-19, including a discussion of recent enforcement actions against pharmaceutical and medical device companies. We'll then briefly touch on a key topic under the federal Anti-Kickback Statute where we've seen some additional enforcement action. We're then going to talk about free products in the wake of COVID-19, issues that we've been seeing with changes in ASC reimbursement, including the resurgence of what I refer to as ambulatory surgery center-related physician-owned distributorships, and some challenging pricing issues there. Then turn to challenges with research on during COVID-19, and finish up with best practices for addressing fraud and abuse risks based on some of the key enforcement actions that we've been seeing over the last 6 to 12 months. So the current enforcement environment is fairly problematic, and one of the issues that we'll be talking about today is the Anti-Kickback Statute, federal criminal statute, an anti-bribery law that, as many of you are aware, prohibits offering, paying, soliciting, or receiving anything of value to induce or reward purchase of medical device products that may be reimbursable by federal healthcare programs. So during the COVID epidemic, there are no current waivers for medical device companies, unlike for physicians and other provider types in the industry. And the federal government has continued to aggressively pursue medical device and pharmaceutical manufacturers for violating the Anti-Kickback Statute during the COVID-19 epidemic. As you may be aware, CMS issued blanket waivers accepting certain arrangements under the Stark Law, and then the Office of Inspector General of the Department of Health and Human Services issued a policy statement announcing enforcement discretion over COVID-19 anti-kickback violations for certain circumstances involving other provider types, but expressly indicated that they were not applying that enforcement posture policy for medical device or pharmaceutical companies. So in the current environment, we do not have a waiver or a special exception because of COVID that's applicable to the life sciences industry. The Office of Inspector General has often in the last year and a half expressed a somewhat negative view of the medical device and pharmaceutical industry. In the proposed rule at the end of last year, where the Office of Inspector General was proposing new safe harbors to the Anti-Kickback Statute and exceptions to civil monetary penalty laws for value-based care arrangements, the OIG expressly excluded medical device and pharmaceutical companies from most of the protections under those proposed rules, and indicated that they were concerned that medical device and pharmaceutical companies might misuse the proposed value-based safe harbors as a means to effectively offer kickbacks or bribes to their potential customers, rather than a means to create value for patients and healthcare systems. The OIG went even further to express their negative views of industry and, in fact, solicited public comments to support the perspective that medical device manufacturers might misuse value-based arrangements to disguise improper kickback arrangements. So in the current enforcement environment, we've seen the federal government at the end of last year and then through the enforcement efforts they've taken this year and the fact that there is no COVID-19 waiver for industry, been fairly aggressive and clear that they intend to prosecute fraud and abuse violations in the pharmaceutical and the medical device industry. So I want to talk to you about a few of the cases that we've seen over the last 6 to 12 months during COVID and the ramifications of those cases in terms of addressing compliance issues as they arise. So the first is BioInnovations, and this is from last month in August. This is a medical device distributor that works for a spinal implant manufacturer, and its owner, John Balzer, and an orthopedic surgeon pled guilty to setting up sham consulting arrangements to induce the surgeon to use the spinal implant manufacturer's products. The spinal implant manufacturer also had to pay a significant settlement, but the pleas from last month included 1-year sentences of supervised release. A pharmaceutical case you may have seen in the news last month, Teva Pharmaceuticals, the U.S. government filed a complaint against Teva alleging that they conspired with a specialty pharmacy and 2 foundations to violate both the federal Anti-Kickback Statute and the False Claims Act, effectively by using these foundations to subsidize Medicare copays for one of their drugs. Teva allegedly referred its Medicare patients to the pharmacy. The pharmacy then reached out to these 2 foundations to obtain copay support, and then the pharmacy allegedly reported back to Teva the number of patients receiving copay assistance so that Teva could determine how much money to donate to each foundation. So as you may be familiar, waiving copays or deductibles, paying copays or deductibles, providing that type of support raises concerns under the Anti-Kickback Statute as an inducement to patients and potentially physicians to utilize drugs or medical device products. Now, you may be asking, why are we talking about foundations in the medical device space for these types of patient assistance programs, these PAP programs, a lot less common in the medical device space? Well, the reason is we've been seeing, and we'll talk about later today, significant volume of requests for free products during COVID-19. Medical device manufacturers are getting quite a few requests. And so understanding the government's enforcement posture regarding providing support, reportedly charitable support, to assist patients and health systems is important to understand the risks associated with responding to those donation requests. So the issue here was that the arrangement set up by Teva did not comply with the governmental guidance regarding setting up patient assistance programs with charitable foundations, including blinding the donors from the recipients in terms of the recipients knowing where financially the support was coming from, and effectively allegedly directing this assistance to their own patients. Teva earlier this year had another problem and paid $54 million to settle allegations relating to a sham speakers program. And the allegations in this case were that physicians were only permitted to remain as speakers if they increased the number of ordered prescriptions. And rather than paying speakers on a fair market value basis for the amount of time that they were spending preparing and presenting, they allegedly paid speakers on the basis of a return on investment analysis. So again, under the Anti-Kickback Statute, the allegations were that they were overcompensating or compensating physicians for providing little to no services in an intent to induce or reward those physicians for ordering their products. Another case you may have seen in the news from July is Novartis Pharmaceuticals. Novartis agreed to pay $591 million and enter into a 5-year corporate integrity agreement to settle anti-kickback allegations, again, regarding sham speakers programs, similar to the Teva case. In this circumstance, there were allegedly no meaningful presentations. Most of the speakers program events occurred at Michelin star or very high-end restaurants without an audience that you would expect to attend these presentations, mostly friends, families, and colleagues of the presenting physicians. There were also allegations that cash payments and recreational outings, including fishing trips and sporting events, were provided. But the key allegations here were that lavish meals were provided frequently to physicians and speakers, and alcohol to induce their prescription of cardiovascular and diabetes drug prescriptions. The sales representatives were allegedly involved in the speakers program, and allegedly selected high-volume prescribers to serve as speakers and dropped them from the programs if they failed to write more prescriptions. Novartis also paid $51 million to settle allegations that it also used foundations to inappropriately pay the copays of Medicare patients. And U.S. Attorney Lelling gave us an insight in the DOJ announcement regarding the settlement into what the government's perspective is on these types of foundations. And the view there was effectively, if you're using a foundation to funnel money to your own patients, to induce them and to induce physicians to use drugs, in this case for copay assistance, the government's view, U.S. Attorney Lelling's view, was this is not charitable giving, but rather intended as a kickback because you are effectively funneling money to patients to self-refer and providing a benefit to the physicians, knowing that their patients are not going to be burdened with the high cost of those drugs. Again, relevant when we talk about a lot of the donation requests that medical device companies are getting later today. A few more cases I just want to bring to your attention. So July 2020, Pacira agreed to pay $3.5 million to resolve allegations that it provided kickbacks in the form of fraudulent research grants to induce physicians to prescribe their drugs. The sales representatives were involved rather than medical education in initiating these research grants. The grants were allegedly contingent upon the placement of the drug on the provider's formulary. And this is a case of sham research. And so the allegations here also included that Pacira did not require providers to adhere to the protocol, made payments regardless of whether or not tasks required by the protocol were actually achieved. And we've actually been seeing an increase in the last year or so in the number of research studies that are structured inappropriately or may not be bona fide or may not generate information that's really needed by the industry sponsor. And we've been seeing an uptick in enforcement and review of what the government views as sham research studies. Merit Medical, in June of this year, the government joined a key TAM lawsuit that alleged that Merit Medical engaged in a kickback scheme relating to its embolization and occlusion microspheres. The allegations here included that Merit Medical was providing free advertising for its loyal users. And so we've actually been seeing an uptick in the past year, likely as a result of changes to the AdvaMed code and its discussions about co-marketing, and also due to some industry participants and service companies out there encouraging co-marketing arrangements. But we've seen an uptick in co-marketing and just direct free advertising for physicians, their practices, and ASCs and others. So it's very important to ensure that if there is any co-marketing, that all of the I's are being dotted and T's crossed. But here are the allegations that free advertising was being provided to users of their products intended to induce or reward them for their use. There were also some sham consulting arrangements, all expense paid trips to Paris, Ireland, and Hawaii. Interestingly enough, the Merit Medical case was filed by Merit's former chief compliance officer, which is fairly uncommon. And the issue here was the chief compliance officer indicated that his concerns were not being addressed by management. And so it's very important, and I know many of the individuals on the line today and joining us are in-house attorneys for medical device companies. Very important to try and explain to management and get management to buy into your compliance program and for compliance concerns that are raised to be addressed. While it's relatively uncommon for a compliance officer themselves to file a key TAM lawsuit against their former employer, we very frequently see former employees filing lawsuits against manufacturers, and principally when their compliance concerns are not addressed. So very important to ensure that compliance issues, when raised, are appropriately addressed, reviewed, and that the tone is set at the top, and that management takes ownership of compliance and ensures that concerns are being reviewed and appropriately addressed. Just two more cases I want to briefly bring to your attention before we talk on a few other issues that are more COVID-19 related. At the beginning of this year, ResMed, a manufacturer of sleep equipment, agreed to pay over $37 million to settle anti-kickback allegations that it was providing free call center and patient outreach services to certain durable medical equipment companies. These were distributors and suppliers that purchased ResMed equipment, and they were allegedly providing something of value, driving business to the DME companies through these call center and patient outreach services. They also allegedly provided some free below-cost equipment and also guaranteed for free loans that these distributors and suppliers were obtaining from third parties to purchase ResMed equipment. So if your companies provide loan guarantees to any of your distributors and suppliers, I think you'll want to look very carefully at those arrangements because they do raise significant concerns. ResMed also allegedly provided some non-sleep specialist physicians with free home equipment, home sleep testing equipment. So again, allegations were that all this was provided to induce or reward the purchase of their products. And then the last case, which I wanted to bring to your attention, which is from last year, is interesting because there are some FDA issues as well. So Acell, manufacturer of a topical wound treatment product, pled guilty to civil and criminal charges, paid $15 million, and entered into a 5-year corporate integrity agreement to resolve allegations that included the provision of free products, entertainment, and again, we see speakers' fees in violation of the Anti-Kickback Statute. There was also allegations of off-label promotion. Their product was approved for external use, but sales representatives were marketing it for internal use. They also had some endotoxin contamination with certain lots of their products that they pulled off the market, did not report that withdrawal to the FDA, and so that was an additional factor in this case. And they were also providing erroneous coding recommendations to their customers so that they could try and obtain greater reimbursement from Medicare for their customers. However, that coding advice was erroneous. Wanted to transition to discussing one key issue that we've seen in the past 6 to 18 months under the federal Anti-Kickback Statute, and really relates to, and as we talked about earlier today, the Anti-Kickback Statute is a criminal statute, an anti-bribery law. And the issue that we've been seeing prosecutors focus on is under a doctrine that's referred to as the one-purpose test. So the federal government and many courts have interpreted the Anti-Kickback Statute as prohibiting any arrangement if even one purpose of the arrangement, if even one purpose of providing something of value is intended to induce or reward referrals or purchases, then it violates the Anti-Kickback Statute in terms of satisfying the willing and knowing requirement of a violation. So we've seen in the past 6 to 18 months, in particular coming out of the Southern District of New York, but we've seen other jurisdictions also aggressively enforcing against manufacturers, even for otherwise completely legitimate arrangements. So if under the one-purpose test in one particular case, there was documented evidence that a manufacturer was reviewing consulting payments to physicians and analyzing those on a return on investment basis. So looking at the purchases by their consultants and doing a return on investment analysis to determine whether or not to continue, these are the allegations, to continue with the consultants. And however, the services that the consultants were providing were completely otherwise legitimate, bona fide training and education services. So we've seen a willingness of the federal government to prosecute cases for otherwise completely legitimate arrangement, otherwise legitimate compensation, fair market value, except that there was a smoking gun evidence that the one purpose test was violated, that one of the reasons for this arrangement, for the selection of the physicians, was intended to induce or reward their product usage. So we've seen a significant uptick in enforcement, and so it becomes very important now to ensure that your companies, their sales team, up through management understand the risks of making statements, sending emails, sending text messages that could be used as evidence to prove that one of the reasons for a relationship with a physician or a member of a purchasing committee was to induce or reward purchases. And so this is becoming a greater problem than we've seen in the past. As you're aware, the penalties for violating the Anti-Kickback Statute are significant. Fines of up to $100,000, imprisonment for up to 10 years or both, civil monetary penalties in excess of $100,000 for each violation, plus 3 times damages. Conviction of a violation of the Anti-Kickback Statute, of course, will now result in mandatory exclusion from federal health care programs for a period of 10 years, as well as under the Affordable Care Act, and through today, any claim for an item or service that was referred or occurred in violation of the Anti-Kickback Statute is now a false claim under the False Claims Act, which separately entails penalties of between $11,000 to now almost $23,000 per claim. So very significant penalties for violation of the Anti-Kickback Statute. So I now want to turn to a discussion of some more COVID-related topics. Neshko will be talking about some of the free product requests that manufacturers have been receiving and some issues and best practices for addressing those requests. Neshko?
Thank you, Sam. One of the issues we have seen is rise in requests for free products during the COVID-19 pandemic. As you may be aware, providing free products to existing or potential customers raises significant kickback concerns if they are intended to induce a provider to order products in the future or to reward the provider for past purchases of products. Manufacturers should make sure to take appropriate precautions in deciding whether or not to donate free product. Ideally, requests for donations of free products should be referred to an independent not-for-profit foundation established for fielding such results, which follows the guidelines established by the OIG for charitable assistance foundations, such as blinding the identity of requesters from the medical device companies that fund the donations. However, what we're seeing more and more of is that manufacturers are receiving direct requests for free products from their established or potential customers, and this is where the risk of government enforcement action for potential kickback violation is significant. As you're likely aware, there is no anti-kickback statute safe harbor currently available that would protect these types of donations, and additionally, there's no COVID-19 waiver currently in place available to medical device manufacturers that would cover providing free products or fulfilling donation requests. Therefore, manufacturers that provide free products could potentially be exposed to liability under the Anti-Kickback Statute and then consequently under the False Claims Act as well. If a manufacturer does decide to provide free products and take on this risk, there are certain steps that they can undertake to reduce the risk under the Anti-Kickback Statute. Manufacturers should treat requests for free products during COVID-19 pandemic in the same way that all requests for grants and donations should be treated. These requests should be made in writing, and they should be appropriately vetted in accordance with companies' policies and procedures. Now, the best way to evaluate these requests is to establish a grants and donations committee within the company to make determinations on awarding grants and donations. These determinations should be based on predetermined criteria, including an annual budget for the total amount dedicated to charitable support, the types of charitable donations supported by the organization, an annual evaluation of requests based upon objective criteria, predetermined objective criteria, and so on. But most importantly, the decision-making process for whether or not to grant the request for free products should not involve sales and marketing personnel. And sales and marketing personnel should not be offering free product to existing or potential customers. To the extent that a marketing or sales representative is involved in the process, it should be limited to providing information about the proposed recipient, but not concerning the recipient's past or potential purchases of products. Additional protective measures that manufacturers should consider include the following. If an existing customer requests free products and threatens that they will cease using the product if they don't receive some free product or a donation, the company should consider disqualifying the request as tainted under the one-purpose test under the Anti-Kickback Statute. Now, the company should also have a policy that it uses objective criteria to make decisions on donations, and that decisions will not be based upon the potential, continuing, or historic purchases of company products. And also, there should be a way to communicate this policy to the customers. On the other hand, if the request comes from a potential customer with a message that says that they will start using the product, but only if they receive the donation, then again, the donation request should be disqualified as tainted under the one-purpose test. Manufacturers should also only award grants to trusted organizations that are aligned with the manufacturer's mission and values, preferably during the COVID-19 pandemic. These would be charitable and not-for-profit organizations impacted by COVID-19 that provide free services to patients impacted by COVID-19. Manufacturers should also not advertise or proactively offer free product, as the government will likely be monitoring this activity and scrutinize any such grants or donations of free product for potential improper inducements under the Anti-Kickback Statute that are intended to induce or reward purchases of the manufacturer's product. Manufacturers should also consider establishing financial hardship criteria, which would limit the types of recipients to those that are experiencing a hardship due to COVID-19, and which would require recipients to use the donated product exclusively on the patients that satisfy the predetermined hardship criteria. And then manufacturers should also consider prohibiting the recipients from billing third-party payers from donated products. However, we note that even if a manufacturer adopts these safeguard measures, because there is no AKS protection for the provision of free product during COVID-19, manufacturers may still face enforcement action. And accordingly, manufacturers should carefully consider whether or not they want to fulfill requests for free products. With that, I'll turn it over back to Sam, who will discuss some of the other trends we have seen during the COVID-19 pandemic.
Thank you, Neshko. And with respect to free products, again, of course, the safest decision there, consistent with the OIG's enforcement efforts against pharmaceutical companies, would be to not directly provide these types of charitable grants and donations, and to go through a foundation that's appropriately structured, but realize that in the current crisis, some companies are moving forward with these more risky arrangements. And I want to talk to you briefly about another issue that we've been seeing coming up during COVID-19, which are some changes to ASC reimbursement and some pricing issues, and what I refer to as ASC-related physician-owned distributorships, which we've seen popping up in response to some of the ASC reimbursement changes. So we recently seen a trend in surgical procedures being shifted from the hospital to ambulatory surgery centers, both as a result of COVID-19 as well as cost and as a result of reimbursement changes. There have been a number of commercial payers as a result that have modified their ambulatory surgery center payment policies, and some of those changes include refusing to pay for instruments or ancillary products such as wires, requiring line item detail level invoices in order for reimbursement to be made, and really addressing the total reimbursement that they're paying for ASC-based cases. As a result of those changes, we've seen some ASCs respond and raise questions with medical device manufacturers regarding addressing some of these payer policy changes. We've seen ASCs in some situations requesting manufacturers to modify their pricing on a per payer basis to, from our perspective, effectively circumvent some of the payer requirements. So, for example, that could include for a insurance company that refuses to pay for ancillary products such as wires and instruments to zero out the price on a line item invoice for those line items and correspondingly add those amounts to the price of other products that are reimbursable by an ASC, again, on a per payer basis. And where manufacturers have been hesitant to make these types of pricing changes, we've also seen some of the, and this is more for physician-owned ambulatory surgery centers, we've seen some of those physician owners establish physician-owned distributorships to purchase the product from the manufacturer, then modify the price themselves and resell it to the ambulatory surgery center. As you may be aware, physician-owned distributorships have a history of fraud and abuse enforcement. Historically, physicians would establish a pod so that they could effectively mark up the price on the products sold to the company or healthcare provider and take profit from the pod through an ownership interest so that they could effectively be rewarded for each case that they perform when they're using those products. And the federal government has raised a lot of concern and enforcement action against physician-owned distributorships historically. So the fact we've been seeing a resurgence primarily on the commercial side, however, there is a concern that these pods not only are manipulating pricing on the commercial side, but may be engaged in the same historical type of behavior that they've previously been engaged in before. So I would keep an eye out if your team or your sales and marketing team are negotiating a purchase agreement with an ASC, and then the agreement, they change the name of the entity that's actually purchasing the product, and it's to one of these physician-owned distributorships. So what are the concerns with this type of pricing manipulation? So if a manufacturer agrees, it's informed, the sales representative is informed by the ASC about this payer policy that they want to try and get around to maximize reimbursement, and the manufacturer agrees to manipulate its pricing structure on a per payer basis. So for patients with a specific insurance company, it could expose the manufacturer to liability for insurance fraud or engaging in unfair business practices under the theory that the manufacturer is effectively aiding, abetting, or conspiring with the ambulatory surgery center to violate or circumvent its payers' requirements. Typically, you would see these types of issues be circumscribed to the relationship between the ambulatory surgery center and the insurance company, but there is a concern that if the insurance company or other payer becomes aware of a manufacturer's complicity in trying to help the ASC circumvent the insurance requirements, that the manufacturer could be pulled into litigation. And the argument here is effectively that the price that the manufacturer is offering to the ASC is no longer arm's length. It's no longer a commercial arm's length negotiated purchase because the pricing for certain products is being inflated and zeroed out for others to specifically circumvent payer requirements. Now, in the past, we've seen other types of pricing manipulation that the federal government has prosecuted historically with respect to federal healthcare program protective measures. Engaging in similar type of pricing manipulation could expose manufacturers to potential False Claims Act and anti-kickback liability, particularly with circumvention of managed care type requirements. But historically, what we've seen on the federal healthcare program side are issues relating to selling cost reimbursed equipment at full price or at an inflated price so that the customer receives a large reimbursement in exchange for a significant discount on fixed price reimbursement products. And there's a long history of abuse there. I realize in the recent years that has become less of an issue due to changes in the DRG and hospital reimbursement system. But historically, there has been some enforcement in that space. So one of the challenges here, if a manufacturer engages and accedes to a request of an ASC to modify this type of pricing and is aware of why the ASC is asking for this type of modification, it could lead to a state law case. But we have been seeing the federal government, where it cannot prosecute cases of bribery or fraud and abuse activity, where they can't prosecute it under the Anti-Kickback Statute or the False Claims Act, we've been seeing them bootstrapping state law violations under the Travel Act. And this is a law that allows the federal government to prosecute a company for a state law violation if the mail or interstate commerce is involved. So simply because these are state law potential cases does not necessarily mean there's not a potential federal component here. Now, of course, manufacturers can establish their pricing structures as appropriate on a more broad basis, but we wanted to address caution if you receive requests for pricing manipulation on a per-payer basis, in particular if sales representatives are informed of why these requests are coming through. So it may not trickle up to management or your department or compliance why this change in pricing structure has been requested, but the sales representative may have been told that the ASC wants to engage in some inappropriate circumvention scheme to try and get around a payer requirement and maximize reimbursement. Maybe it's in a state where that's not illegal, but there's the possibility of unfair business practices and potential insurance fraud litigation. And so if the sales representative is aware of this request and accedes to it, there is potential exposure for the manufacturer. So we just recommend you exercise caution in acceding to these requests for per-payer modifications by ASCs to maximize reimbursement, which have really been driven by haircuts and other changes to ASC reimbursement. I want to now turn the presentation back over to Neshko to address some of the issues that we've been seeing with research during COVID-19. Neshko?
Thank you, Sam. As you are aware, the COVID-19 pandemic has had a tremendous adverse impact on clinical research in the United States. There are numerous clinical trials which require an in-person interaction that have been suspended or stalled. And oftentimes the research has been rendered unusable as a result of the COVID-19 pandemic and the lack of direct patient interaction. In light of this, the IRBs have been working closely with manufacturers as well as pharmaceutical companies to attempt to salvage studies by expediting review of modifications to trial protocols, consent documents, and data collection requirements. Additional modifications may require compliance with changing institutional policies, including policies that may restrict interaction with participants and some restrictions on use of institutional sites. For studies that require in-person interaction and that are continuing forward during COVID-19, manufacturers should consider obtaining COVID-19 specific informed consents that address the potential risk of contracting COVID-19 as a separate risk factor. Many industry participants have also been asked to participate in public health activities, which are different from traditional technical research, so manufacturers should be aware of the differences in terms of oversight and regulatory requirements for public health activities as opposed to requirements for clinical research. From a fraud and abuse perspective, COVID-19 has had limited impact on clinical research, but it has had impact nevertheless. Due to the pandemic causing many studies to terminate prematurely, manufacturers should ensure that they are addressing applicable fraud and abuse concerns, including reclaiming products provided for use in studies which have been terminated or scaled down, ensuring that payments or grants for terminated studies are stopped, or if payments were made and visits did not happen or documents were not completed, manufacturers should recover or at least make an effort to recover these payments. If study services were not provided during COVID-19, manufacturers could potentially run into problems with enforcing their clinical trial contracts due to force majeure provisions, which could excuse non-performance due to COVID-19. Now, if a clinical trial agreement is modified to continue during COVID-19, manufacturers should ensure that force majeure provisions clarify that COVID-19 pandemic and the related crisis will no longer be considered a force majeure event, or clarify what exactly will occur in the event of research stoppage due to COVID-19. We will now cover a few best practices for medical device manufacturers to minimize fraud and abuse risks during the COVID-19 pandemic, based in significant part on recent enforcement actions and types of cases that the government is focusing on currently. Sam?
Thank you, Neshko. And I realize that research has been a particularly sore area during COVID-19, and many companies have lost significant investments, but it's important to ensure that your healthcare provider partners and sites, that you're not leaving a terminated research study in a manner that the government could come in and say, well, even though this research was terminated, why did you leave this money with this site or this healthcare provider? So thank you, Neshko. Very, very important insight there. I want to talk about a few best practices arising from some of the cases that we've seen recently. And the first topic I'd like to talk to you about are consultants. And so we've been seeing, as you saw from the enforcement actions we discussed earlier today, a significant increase in prosecution of consulting arrangements over the last few years, including prosecution not only of the medical device manufacturers, but also physicians and others serving in those roles. A lot of the enforcement actions arise, and some of the factors involved include the involvement of sales and marketing personnel in selecting or recommending physicians for consulting arrangements. And in particular, the common fact pattern that we see is a sales representative goes and tries to make the case to management that a physician should be considered for a consulting arrangement because of the number of cases or the volume of business that they've been doing. And so that really raises significant concerns, and oftentimes we see those requests resulting in hot documents or smoking guns that are later used in enforcement actions. Consulting arrangements or other financial arrangements with physicians should never really be discussed in the context of physician utilization, physician purchases, and should not be being used by sales and marketing personnel as a sales tool. And some of the issues we've seen in particular numerous times in the past year coming up is a return on investment for physician consultants. So the amounts paid to physician consultants should have nothing to do with their product usage, their volume of usage, and the amount that they're paid for the services should be fair market value. But importantly, not only at the sales and marketing level, but also at the management level, you should be careful in instructing management to avoid, and this often comes from finance, to avoid creating spreadsheets that compare physician consultants' purchases or usage to the amount of spend on those physician consultants. Once you go, and certainly companies are free to establish budgets for physician consultants and speakers programs, et cetera, but once you go from a budgetary line item to comparing spend on a physician consultant to the amount of business that they're generating, that's where you get into pretty good evidence that one of the purposes behind the consulting arrangement, maybe not the primary purpose, was to induce or reward the business they're generating. And we've seen numerous enforcement actions where evidence of ROI is effectively the smoking gun that causes a settlement. Consulting arrangements with physicians and others should also be structured to substantially comply with the personal services and management contract, safe harbor to the Anti-Kickback Statute as well. I want to talk briefly a little bit more about physicians, consultants, and sales representatives. So sales representatives should never offer a consulting position to a physician, and those decisions on consulting positions should be solely based on the physician's credentials and should not take into account the historical volume of purchases or potential business from a physician. Now, I realize certain types of consultants, you may need to have someone experienced and very familiar with your company's products in order to engage in research or to speak publicly about those products. But the concerns that we've seen here, what you don't want to have happen is someone prepare a spreadsheet listing the physicians in volume of business they've generated and picking the individual at the top of the list. If experience with your products is one of the criteria, I would list it as one of the criteria that they're familiar with and have experience with your products, but not make decisions on the basis that a physician is at the top of the list, and really look more to the expertise and credentials of a physician. In terms of recommending physicians for consulting roles, sales reps may recommend physicians and forward on their CVs and other information, but really should not be involved in any decision to choose a physician for a consulting role. And ideally, those types of decisions will be made by an independent committee without any input from sales and marketing. If a physician requests that he or she be considered for a consulting role, the best practice would be for the representative, to indicate that they're happy to forward the request, but to clarify that the sales representative has no ability to influence that decision, and that while they appreciate the physician's business, that that business will not in any way be considered in deciding whether or not to select a physician for a role. I want to turn it back to Neshko for a few minutes here to speak briefly about a specific area of consulting where we've seen a lot of enforcement, which is in speakers programs. Neshko?
Thank you, Sam. Speakers programs have remained the focus of federal prosecutors, and as recent enforcement actions show, the government continues to scrutinize speakers programs, and we anticipate that this trend will continue in the future. When developing a speakers program, device manufacturer should develop a process that requires an annual assessment needs to determine physician consulting needs for the upcoming year, including qualifications and credentials necessary to fulfill these roles, as well as a determination on what the budget will be for the speakers programs, and the actual legitimate marketing and educational need for the roles these consultants are fulfilling. The manufacturer should also develop a standardized process to identify consultants based solely on the credentials of the physicians, which do not in any way take into account past or future purchases or orders of company products. Now, the amount of compensation that consultants are paid must be fair market value for the services provided by the physician. And for speakers programs in particular, it's important to establish limitations, such as only paying consultants for the time that the speaker is presenting and potentially for some preparation time. While there's an industry practice of paying for travel time, we recommend that manufacturers try to avoid or minimize the amount paid for travel time and to establish reasonable limitations on travel costs and compensations. We have seen concerns raised about inflated payments to speakers that include additional amounts paid for travel time. For example, if a manufacturer always flies physicians across the country to speak at events and pays significant compensation for travel time, but never uses local qualified physician speakers, even in large markets, the government could allege that the program is not commercially reasonable and that it's actually a sham because it is intended to generate inflated payments to speakers to induce them to use the manufacturer's products. There are some additional aspects of speakers programs manufacturers should keep in mind that the government has expressed as characteristics of sham speakers programs and which usually raise red flags. Some of the characteristics the government reiterated in the past are low participation or attendance or repeat speakers or attendees. For example, having only the physician staff, colleagues, or even just family members at a speaking event is not going to be considered a bona fide speakers program. Rather, it's likely that this will be viewed as a meal rewarding a physician for his past purchases, and an event of this type would create significant risk. We have also seen speaker programs where the manufacturers would create events where they would take a group of physicians to an upscale restaurant for dinners, and then the physicians would rotate and give the same presentation to their colleagues over and over again. This type of an inappropriate arrangement also touches on another characteristic the government pays close attention to, and this is the venue that these speaker programs are conducted at. It is important to have an appropriate venue for speakers programs. The government has identified inappropriate venues, and these include resort areas with seasonal recreational attractions, high-end restaurants with no audiovisual capacities or separate rooms appropriate for presentations. So, for example, having a dinner on a Saturday night in the middle of a floor at a Michelin-star restaurant is not going to cut it for a speakers program. Another characteristic of a sham program is a program with no prepared remarks or presentation. Therefore, if you have a speakers program and there are no prepared remarks or a presentation that the physician created for the speakers program, it significantly increases the risk that the speakers program is going to be considered a sham. Lack of documentation, that's another characteristic of a sham program. A protective measure we recommend clients undertake to address this issue is to take attendance. And in certain cases, we have had clients follow up with attendees and confirm their attendance and keep audited program records. So taking attendance and making sure that there's appropriate documentation about the speakers program is an easy yet effective safeguard. Excessive payments to physicians. Now, this characteristic may be in the middle of our list, but this is definitely the main factor that the government will look at. As I discussed before, main issue is that the amount is fair market value for the services provided, and that it is based on the amount of time that the speaker is presenting and preparing for the program. Now, whether the manufacturer structures the payment as a flat payment or based on an hourly rate, it still needs to come down to the same fair market value for the services provided. We have seen courts carefully break down amounts paid to speakers based on hourly basis to determine whether the payments were excessive. Subject matter of the program also needs to be relevant. If the physician is giving a presentation on something completely irrelevant or not relevant to the specific audience, that can also be a factor indicating that the program is a potential sham. Selection of speakers should be based on their credentials and never on the volume or value of their past or future purchases. The speaker must be someone with experience and authority on the use of the product, and even more importantly, there has to be an actual bona fide need for the speaking engagement. If the intent of the program is to induce or reward the speaker for ordering or purchasing a product, this is not going to be a bona fide speaking engagement. There has to be some type of an educational component included in the equation. Speaking engagements intended solely to generate product purchases and sales will definitely raise concerns. The government has also stated that speaking engagements that are being arranged to drive referrals to surgeons who use the manufacturer's products, as well as arranging for speakers programs with no educational purpose, are intended to provide something of value to the physician, and therefore these programs raise risk as potential prohibited remuneration under the Anti-Kickback Statute. And of course, please don't take this as an exhaustive list. We note that this is not an exhaustive list, and we note that the government takes a case-by-case approach in evaluating speaker programs and scrutinize the facts of each program carefully. I'll turn it over back to Sam now for some additional best practices we derived from past and recent enforcement actions.
Thank you, Neshko. Appreciate that. And I know we're running a little low on time here, but with respect to speakers programs, some of the key issues that we've seen are perhaps otherwise legitimate speakers programs being tainted under the one purpose test because sales representative or someone in management or maybe an account manager sends an email internally about their program, and that email ends up being discovered during an investigation. So it's really important to always consider the one purpose test and to really train in your compliance training, ensure that all employees at your company understand the one purpose test and that they should not be sending emails or text messages that could potentially taint otherwise completely legitimate activities that your company are engaged in. I mean, we've seen emails and text messages. Employees need to assume that they're going to last forever because we've seen them become Exhibit A in criminal prosecutions and civil prosecutions over and over again. And through your compliance training, you should be educating not only sales reps and managers, but also management and executives that before they hit send on a message, or specifically before they hit send on a text message, could this be viewed as an offer or acceptance of a kickback or acknowledgement that one of the purposes behind a financial relationship is to induce or reward referrals. So statements we've seen include statements like, we need to keep this physician loyal or establish brand loyalty with this physician. Let's put them on our speakers bureau. Those types of emails, which at first blush may seem innocuous, may taint an entire program. We've also seen entertainment coming back, so sales representatives should not pay both with company dollars or out of their own pocket for entertainment or other recreational events. And where we've seen this come up a lot is at gala or foundation events, where a manufacturer purchases a table for quite a bit of money and then invites physicians to have a free spot at their table, which effectively is, a $300-400 seat. We've seen that happening, unfortunately, quite often and raising significant concerns. Meals, again, I realize there's an industry practice here, but we have seen a lot of enforcement actions, particularly involving high-end restaurants with significant meals, particularly if they're occurring frequently with the same physician or even multiple times in a one-year period. May raise some concerns about the bona fide nature of those meals. From a procedural compliance perspective, I think it's important to establish a culture of compliance at your company, ensure that your policies are actually matching the practices, and ensuring that management has buy-in to compliance. That means that management should not be butting heads with compliance, but should be finding a way to work collaboratively with compliance to address appropriate issues. As we saw in the Merit Medical case, you can have compliance personnel that end up becoming key TAM relators, so important to make sure that the parties are working together. And also other good communication practices, and I know we're just about out of time here. Text messages are a very significant problem. We've seen by nature, individuals just do not have the same level of censorship before sending a text message as they do before sending an email. So we recommend that you prohibit everyone at your company from sending text messages to potential referral sources or physicians. But moreover, I think it's really important to train on this. We've seen time and time again the Department of Justice obtaining text messages and really using those text messages to prove that the one purpose test was violated. We've also seen some inappropriate relationships between sales representatives with referral sources. So important to vet and have your policies require sales representatives to disclose their financial relationships with referral sources, including relatives of referral sources. We've seen joint ventures to share commissions between sales representatives and physicians. We've also seen sales representatives hiring relatives of referral sources to provide sham services, such as hiring a referring physician's child to redesign the sales representative's home when nothing was really provided, or offering the free use of their vacation home. Also important to keep in mind the venues that you're having events at. We've seen a lot of focus in the past by the DOJ for events at venues such as bars, casinos, or strip clubs. If they can allege some sort of impropriety, makes a good headline, and they're very interested in those types of enforcement cases. So in wrapping up, I just want to leave you with some important thoughts that internally it's important to ensure that your companies and your employees, even your contractors, are aware of some of these concerns, and ensuring that if they're not generating emails or text messages that turn into a smoking gun, innocuous messages such as, we want to take you out somewhere to celebrate your 100th case have come back to haunt many manufacturers. And finally, just in summary, one last issue that I want to leave you with is going back to the beginning of our discussion today and talking about return on investment. We've seen more and more prosecutions under the one purpose test for otherwise bona fide relationships with healthcare providers. So thank you everyone for joining our webinar today regarding compliance concerns in the wake of COVID-19. As a reminder, this is part 1 of 3, and our next webinar will be in around 2 months and addressing pricing discount and other arrangements with your customers. Thank you all for joining us today. Really appreciate your time.
Thank you, everybody.